Good morning, ladies and gentlemen. Today, I'm going to talk on a very important topic, and that is the dermatoses which are related to pregnancy, the specific dermatoses. 1/3 of the affected women, that is the women who are pregnant, will have either a specific dermatosis of pregnancy or will have some non-specific issues. Among the specific dermatoses of pregnancy, the important ones are the atopic eruption of pregnancy, the polymorphic eruption of pregnancy, Pemphigoid, gestationis, and Impetigo herpetiformis. While there is a specific illness that is, although not a dermatological illness, but is associated with pruritis, and that is the intrahepatic cholestasis of pregnancy. There will be 2/3 of the women who will be scratching and itching, but is not suffering from any specific dermatosis of pregnancy, and these women will be classified as Pruritis Gravidarum. Most pruritus during pregnancy is of symptomatic significance only. But some conditions like Pemphigoid gestationis, intrahepatic cholestasis, and Impetigo herpetiformis are associated with adverse events to the fetus. And these conditions need to be identified, diagnosed, and managed to reduce the perinatal morbidity and mortality. The dermatoses of concern can usually be identified on clinical grounds, but some specific investigations may be required, especially the skin biopsy. Atopic eruption of pregnancy has an earliest onset during pregnancy, usually in first and second trimester, in those patients who are already suffering from atopic dermatitis. Pemphigoid gestationis may occur early, but usually it is of late onset and has a peculiar peri-umbilical distribution and progress to bullous lesions. Polymorphic eruption of pregnancy and intrahepatic cholestasis of pregnancy both have late onset, that is the third trimester. And the polymorphic eruption of pregnancy starts usually at the stretch marks or the stria gravidarum and typically spares the peri-umbilical region, which is the area bullous, the pemphigoid gestationis is involving. The Pruritis Gravidarum and intrahepatic cholestasis of pregnancy have no primary skin lesion and produce intense itching on the body, including palms, and whatever lesions are seen are mainly due to this itching and scratching. There is considerable overlap in clinical presentation and histopathology between pregnant women with atopic eczema, with prurigo of pregnancy, and pruritic folliculitis of pregnancy. So all these three conditions are now grouped together as atopic eruptions of pregnancy. So the first condition we are going to discuss today in this chapter is the Pruritis gravidarum and intrahepatic cholestasis of pregnancy. Pruritis gravidarum is considered by most to be a mild variant of intrahepatic cholestasis of pregnancy, occurring in approximately 0.03 to 3% of pregnancies. There is poor correlation of severity of itch and serum bile salt elevation or levels. The accuracy of serum bile salts in diagnosing intrahepatic cholestasis of pregnancy is not clear according to the Cochrane review, and this may explain that the large number of women presenting with typical pruritus of intrahepatic cholestasis will not have any corresponding laboratory findings. Therefore, some authors classify Pruritis gravidarum as with or without cholestasis. So this is a better way to classify that Pruritis gravidarum with cholestasis, in which there is disturbed LFTs, and Pruritis gravidarum without cholestasis, in which The LFTs are absolutely normal. Pathophysiology. The intrahepatic cholestasis of pregnancy is a reversible form of hormonally triggered cholestasis that typically develops in genetically predisposed individuals in late pregnancy. So, due to the hormonal influence of pregnancy, the bile becomes stuck up in the ducts, resulting in cholestasis. The cause is thought to be multifactorial. So there are no typical skin lesions, and whatever we see on the skin is because of the itching, which begins at second or third trimester and often localized to abdomen, palm, and soles, and sometimes it may be widespread. About 10% of cases may be mildly jaundiced. Secondary skin lesions are due to scratching and range from subtle excoriations to severe prurigo nodules as the pruritus persists. The disease course and prognosis. Prognosis for the mother is generally good. After delivery, the pruritus disappears spontaneously within days to weeks, but it may recur with subsequent pregnancies and if oral contraceptives are used. The Pruritis Gravidarum with bile salts less than 40 micromole per liter is not associated with poor perinatal outcomes, and only symptomatic treatment is sufficient. If there is jaundice, high serum bile salts, patients are at risk of developing steatorrhea and malabsorption of fat-soluble vitamins, including vitamin K, and is predisposed to bleeding complications and cholelithiasis. So it is important to measure the bile salts and other liver enzymes in all such patients. The fetal prognosis may be impaired with increased risk of prematurity, fetal distress, and stillbirth. Therefore, prompt diagnosis, specific therapy, close obstetric monitoring, and maternal counseling are all essential in such patients. So the basic and foremost investigation in pregnant women presenting with pruritus with no other clinical signs of any other disease is the liver function test, which is normal in most cases. The alkaline phosphatase may be raised, but which is the normal finding in most pregnancy, but it is mildly raised. Serum bile salts can be raised, another option, another scenario. In healthy pregnancies, total serum bile acid level may increase up to 11 micromole per liter in third trimester. But if the bile salts are raised beyond 40 micromole per liter, then it is dangerous, and this patient should be managed to manage with increased preterm delivery because the fetus have chances of having a preterm delivery, the meconium staining of amniotic fluid, and asphyxial event. So all the patients who are having high bile salts should be prescribed ursodeoxycholic acid, UDCA, which is the treatment of choice based on small studies that suggest that it improves the maternal itch and reduce the fetal abnormality and mortality and morbidity. Studies are needed to determine if there is a benefit in high-risk group with serum bile salt more than 40 micromole per liter. There do not appear to be any safety concern with the use of UDCA in pregnancy, and it would be reasonable to trial in symptomatic women. So all such patients having pruritus, having high bile salts, should be given a trial of UDCA. There is little evidence to support the use of activated charcoal as adenosyl L-methionine, dexamethasone, or cholestyramine. Of note, cholestyramine and other bile acid exchange resins may contribute to malabsorption of vitamin K with possible bleeding complications and hence should be avoided. There is a requirement of close obstetric surveillance in all such women. Stillbirth is sudden of occurrence, and there is no evidence that weekly fetal cardiac monitoring prevent this. But regular obstetric review may pick up growth retardation and early fetal distress. So this is the treatment ladder for pruritus gravidarum and intrahepatic cholestasis of pregnancy. The first line is the emollients, aqueous cream with 1 to 2% menthol. Then oral histamine, both loratadine and cetirizine are safe. Then oral UDCA 1 gram per day. In second line is L-adenosine, methionine, dexamethasone, and cholestyramine. Other recommendations are fetal cardio tocography to monitor the fetal heart rate and detect early signs of fetal distress when the bile salts are high, that is more than 40 micromole per liter. Maternal vitamin K replacement is also required if jaundice is present, and early delivery should be planned by 36 to 37 weeks. Then dexamethasone may be needed if fetal lung maturity is doubtful. The second condition to consider is atopic eruption of pregnancy. It is the most common specific dermatoses of pregnancy, accounting for 50% of patients. It's a benign pruritic disorder that include eczematous or papular lesions in patients already having atopic diathesis. It starts early in the pregnancy, and 75% of the cases present before third trimester, and it tends to recur in subsequent pregnancies. So all atopic patients who are planning to get pregnant should be told and warned about this possible complication. The pathogenesis of atopic eruption of pregnancy is thought to be triggered by pregnancy-specific immunological changes. So there is increased Th2 cytokines, interleukin 4 and 10, which causes increase in humoral immunity. Then there is reduction in cellular immunity, and there is reduced production of Th1 cytokines like interferon 2, interferon gamma, interleukin 2, and 12. Clinical features. 20% of patients suffer from exacerbation of pre-existing atopic eczema with typical clinical picture. So it is not difficult to diagnose the atopic eczema in such patients. The remaining 80% experience atopic skin changes for the first time. Two-thirds of patients present with widespread eczematous changes affecting the typical atopic sites like face, neck, decollete, and flexural surfaces of the limb. And they are called as the E-type of atopic eruption of pregnancy, E-type, the eczema type. Then one-third of the patients have papular lesions and are known as the P-type of atopic eruption of pregnancy, characterized by small red papules, which are disseminated on the trunk and limbs, and have a typical prurigo nodularis-like appearance, and mainly located on shins and arms. A significant key feature in such patient is the dryness of the skin. Disease course and prognosis. The maternal prognosis is good even in severe cases. Response is quick to the therapy. Recurrence in subsequent pregnancies is common. The fetal prognosis is unaffected by this condition. Histopathology is usually non-specific and show elevated serum IgE levels in the blood and increase in eosinophil, as you see here, perivascular, lymphohistiocytic and eosinophilic infiltrate is seen in upper derms. The management. Basic treatment is with emollients, topical corticosteroid for several days, which brings quick improvement to skin lesions. Severe cases require short courses of systemic corticosteroids and antihistamines. UVB phototherapy is useful for severe cases in early pregnancy. This is the treatment ladder for atopic eruption of pregnancy. First line is emollients, topical steroids, and oral antihistamines. Second line is the narrowband UVB. Third line is prednisolone and azathioprine. Then the third condition to be discussed today is the polymorphic eruption of pregnancy. Is a specific dermatosis of pregnancy, which is also known as the pruritic urticarial papules and plaques of pregnancy, PUP. It's a benign, self-limiting skin disorder. There is an increased prevalence of this condition in primary gravida, and onset is in third trimester or immediately postpartum. It usually do not occur in subsequent pregnancies. Remission is at the time of delivery and associated with multiple gestation pregnancy and maternal weight gain. There is no associated maternal fetal risk, and treatment is largely symptomatic. Pathophysiology. The main theories focus on abdominal distension and hormonal and immunological factors. The fact PEP starts within stria distensi suggests that damage to the connective tissue due to overstretching play a central role in triggering this dermatosis. The phenomena of peripheral chimerism in pregnancy has also been hypothesized. Serum cortisol levels are found to be low, while HCG and estradiol level are normal. Estradiol level are normal. Unlike pemphigoid gestations, there is no HLA association. The clinical features. PEP typically starts on the abdomen, often within the stretch marks, that is stria gravidarum or stria distensi, and classically spares the periumbilical area, palm, soles, and face. So these are the area of sparing and area in PEP and area of involvement in pemphigoid gestations. Sparing of umbilical area helps in differentiating PEP from pemphigoid gestations. The stria become first itchy, then red, and finally urticated. Rash spread to buttocks, proximal thigh, and coalescing to form plaques. The PEP lesion on the breast. Patients are very uncomfortable, and pruritus is quite severe and disturbs the sleep. And rarely the lesions are excoriated as well. Later, the morphology becomes more polymorphic, in which vesicles, which are small in size 1 to 2 millimeter, but there is never frank blisters, like pemphigoid gestations. There is widespread non-urticated red patches, the targetoid lesions, and eczematous lesions. Rash often resolves within 4 to 6 weeks, independent of delivery. The disease course and fetal prognosis. There is no adverse effect on the outcome of pregnancy or the newborn. So this is a fetal safe dermatosis. Lesions are self-limiting and disease tend not to recur, exception being in multiple pregnancies when the presentation is earlier. Investigation. The histopathology of this condition is non-specific, and there are many similarities in histopathology between this dermatosis and the pre-bullous stage of pemphigoid gestations. Most biopsies show epidermal and upper dermal edema with a perivascular infiltrate of lymphocytes, histocytes, and increased number of eosinophils. There are spongiotic vesicles, hyperkeratosis, and patchy parakeratosis. DIF is negative. So here you can see the skin biopsy with spongiosis in the epidermis, and there is dense perivascular lymphohistiocytic infiltrate in upper dermis. On higher magnification, you can see this spongiosis and lymphocytic exocytosis. Some eosinophils are also seen. Here, the eosinophils are seen in the upper dermis surrounding the blood vessels, and they are also seen here. Management. Symptomatic treatment is with corticosteroids, topical, and emollients, with or without antihistamines, which is usually sufficient to control pruritus in 24 to 72 hours. If the condition is generalized and severe, short course of systemic corticosteroids, 40 to 60 milligram per day, tapering to zero over few weeks is necessary and is effective. Sometimes early induction of labor is to be considered if patient is close to the term. So the treatment ladder of PEP is first line topical emollients with aqueous cream and menthol, topical corticosteroids, oral histamines. Second line is prednisolone and consider early induction of labor if patient is close to term. Now the fourth condition I'm going to discuss is pemphigoid gestations. It is a rare autoimmune bullous disorder present mainly in late pregnancy or immediately postpartum period. It is commonly seen in multigravida pregnancies. It rarely present in association with trophoblastic tumors like choriocarcinoma and herpetiform mole. The incidence is 1 in 2,000 or 1 in 50,000 to 60,000 pregnancies. It has a strong association with major histocompatibility type 2 antigens HLA, DR3, and DR4. And there is an increased risk of developing Graves' disease in such patients. Pathophysiology, the circulating autoantibody complement fixing, IgG, autoantibodies of class IgG1, which are formerly known as the herpes gestationis factor, bind to 180 kilodalton bullous pemphigoid protein known as the bullous pemphigoid antigen 2 in the hemidesmosomes of dermoepidermal junctions, leading to tissue damage and blister formation, almost the same pathogenesis as that of bullous pemphigoid. Of interest is that the primary site of autoimmunity seems not to be the skin, but in the placenta, as the antibodies are bind not only to the basement membrane zone of the epidermis, but also to that of the chorionic and amniotic epithelia, both of which are ectodermal in origin. So this is a thing which differentiates the condition from the usual bullous pemphigoid, that the origin of autoantibody is the placenta, and the similar deposition of IgG class 1 antibodies against bullous pemphigoid antigen 2 is also seen in the epithelia of chorion and of the amniotic epithelium. Clinical feature. The pemphigoid gestation is present with intense pruritus, which precedes skin lesions for few days or weeks. So the early lesions are urticated red papules and plaques, developing in abdomen characteristically involving the periumbilical region but spread to entire skin surface. So at this stage, it is difficult to differentiate it from the polymorphic eruption of pregnancy. And the only point of differentiation is that the disease involves the periumbilical region, also involves face and palm and soles. Extremities are involved in all cases. So in the pre-bullous stage, the differentiation between the bullous pemphigoid gestationis and PEP is impossible. But clinically and histopathologically, both clinically and histopathologically, small vesicles are formed in PEP, but large tense blisters are seen only in pemphigoid gestations. The disease course and fetal prognosis. The natural course of pemphigoid gestationis is characterized by exacerbations and remissions during pregnancy, with frequent improvement in late pregnancy followed by flare-up at the time of delivery, which is seen in 75% of patients. After the delivery, lesions usually resolve within weeks to months, but may recur at the time of menstruation and if hormonal contraception is used. Rarely, the pemphigoid gestationis persists for several years after the delivery. Maternal antibodies can be transferred to newborn, and around 5 to 13% of newborns may develop mild skin lesions, which is known as the neonatal pemphigoid gestationis, which resolves spontaneously within days to weeks. Almost all cases, conservative management is all that is required until the maternal antibodies are cleared from the fetal circulation. Fetal prognosis is generally good, but there is an increase in chances of prematurity and small for dates babies. It is shown that the risk correlates with the disease severity of pemphigoid gestations. Pemphigoid gestationis commonly recurs in subsequent pregnancies and has an earlier onset and in increased severity in subsequent pregnancies. Investigation. The pre-bullous stage is characterized by edema of upper and middle dermis with accompanied perivascular lymphohistiocytic infiltrate with prominent eosinophils. But in later stages, the proper vesicles and then blisters are seen subepidermal location, and these blisters are filled with numerous eosinophils. If we do a direct immunofluorescence studies, then there is C3 deposition at the dermoepidermal junction in 100% of cases and IgG deposition in 30 to 50% of the cases. The circulating serum IgG antibodies may be detected by indirect immunofluorescence. The antibodies levels can also be monitored by ELISA, which shows a good correlation with disease activity. Management. The treatment depends upon the stage and severity of the disease, and it aims to control the pruritus and prevent the blister formation. Topical corticosteroids with or without antihistamines is sufficient treatment for pre-bullous stage. While once the blister develops, the patient would require steroids in a dose of 0.5 to 1 milligram per kilogram per day. As the disease improves, the dose can be reduced, but it should be increased at a time of labor to prevent the flare postpartum. Cases who are unresponsive to oral corticosteroids benefit from third-line treatment that include azathioprine, intravenous immunoglobulin, and plasma exchange. Ultraviolet therapy is relatively contraindicated. After delivery, if necessary, a great range of other immunosuppressive agents can be used, which are contraindicated during pregnancy. If patient have associated gestational trophoblastic disease, then treatment of this disease may also be done after delivery. So this is the treatment ladder for pemphigoid gestationis. First line is again the topical emollients, then the potent topical corticosteroids and oral histamines. Second line are the oral prednisolone. Third line is azathioprine, intravenous immunoglobulin and plasma exchange. The last condition I'm going to discuss is impetigo herpetiformis, or acute generalized pustular psoriasis of pregnancy. This condition represents the generalized pustular psoriasis triggered by or occurring in pregnancy. It is caused by underlying hypocalcemia, low vitamin D, hyperparathyroidism, genetic variation, and hormonal changes. So these are the triggering factors. Onset is usually the late trimester. So again, it's a late trimester disease, but can occur earlier and in the first day of purpurium. The disease tends to persist until the child is born and occasionally long afterwards. Essentially, the features are that of generalized pustular psoriasis, usually have a flexural onset with marked tendency to symmetry and grouping of areas of pustulation. Lesions are not typically itchy like we see in Pemphigoid gestations. Neither there are large blisters nor the lesions are itchy, but rather the lesions are pustular, sheets of pus. Tongue, buccal mucosa, even esophagus may be involved with succinate or erosive lesions in oral mucosa. Plaques may spread to trunk and extremities. So these are the typical pustules of pustular psoriasis. So almost whole body is covered. Hand, feet, and face are generally spared. Plaques become centrally crusted and eroded. As individual lesions heal, there is reddish-brown pigmentation. The constitutional disturbances are characterized by severe fever. Death may occur because cardiac or renal failure. There can be delirium, diarrhea, and vomiting, and tetany is also described. There is a great risk of placental insufficiency, leading to stillbirth, neonatal death, and fetal abnormalities. So the disease classically returns in subsequent pregnancies. Histopathology is that of the pustular psoriasis. There is parakeratosis with Monroe abscesses and large spongiform pustules of Kogoch, as you can see in this picture. So in all pustular psoriasis, there is increase in size of spongiform pustules of Kogoch, along with other psoriasiform changes. The classification of severity, there is no validated severity score, although activity of the disease at a given point of time is categorized as mild, moderate, or severe, depending upon the extent of erythema and pustulation, absence or presence of fever, and the laboratory abnormalities, primarily the leukocytosis, elevated inflammatory markers, and lower serum calcium and albumin levels. There are lots of complications associated with this condition, and it is associated with maternal electrolyte imbalance, especially low calcium, that can lead to delirium, seizures, and tetany. That should be taken care of. Fluid losses, dehydration, as sepsis from infection is also present. Then it recurs subsequent pregnancies and earlier stage and can have a more severe clinical manifestation. It may also develop during menstruation and during while taking birth control pills. Other complications include preterm labor, neonatal demise, fetal growth restriction, premature rupture of membranes, intrauterine fetal death, and placental insufficiency. Managed by oral prednisolone in a dose of 15 to 30 milligram daily. Dose is increased to 60 to 80 mg whenever needed. Topical beta-bathosone, topical corticosteroid like topical beta-bathosone, 0.05% and dose of 15 to 30 gram per day is used. Then dapsone, H1 receptor antagonist, like antihistamines, and colchicine is tried. Acitretin is successful postpartum. Cyclosporin or tumor necrotic factor inhibitors like infliximab and adalimumab may be used in severe cases. Delivery is curative, so the delivery should be considered, especially those who are close to term and are refractory to other treatments. So this brings me to the end of my talk. I thank you all for patient listening and hopefully join you next time with another edition of my lecture. Goodbye and have a very good day.